So good afternoon, everyone. Thanks for coming. Again, I apologize to you all and to our esteemed speaker for booking this on a holiday. Dan, thank you for keeping us on the schedule. It sounds like you had a lot of meetings today, so I feel better that you aren't sacrificing some time on the beach to be with us.
Not at all, exactly.
Of course, we'll have this recorded and we'll put it up on the CGEC website as soon as possible so that folks who couldn't be here today will still be able to enjoy your presentation. For the group we have here live today, we have a special treat. Dr. Dan Barnett, he has worked extensively with the center and several of our faculty in the past, and he's agreed to come and share with us his wealth of experience and expertise in disaster research, and in particular, today on the issue of willingness of healthcare workers to respond to public health emergencies. So obviously a salient topic that's been front and center of our clinical lives for the past couple of years. And thank you, Dan, for making the time for us and for sharing this with us. And I'll go ahead and pass the mic over to you.
Great, thank you, Nico, and thanks to everyone for joining. Yes, this is very exciting to present to CGEC on this topic. As Nico said, I think this is very timely, as it turns out. And although my colleagues and I began this research many years ago, I think COVID-19 really has brought a lot of these issues to the forefront. And obviously this is informal, so any questions, please ask along the way. So basically what I'm going to do is map out our current understanding and next steps research avenues for assessing willingness to respond in public health emergencies and disasters among healthcare and public health personnel. And for several years, as I mentioned, this has been a topic of keen interest of mine from a research standpoint. This is something that is becoming, frankly, ever more salient as we get more frequent and severe disasters, both related to climate change and other kinds of things like industrial disasters and accidents. So let's, against that backdrop, I'll put this in some context here. So this is a very intentionally abbreviated list of 21st century public health preparedness challenges. If I had a full list, it would be basically the length of the entire PowerPoint. So we can broadly categorize these into natural disasters, which we're seeing more frequent and severe natural disasters in the context of climate change, pandemics, also, by the way, something that climate change makes us more prone to, and technological disasters. So against this ever broadening spectrum of public health challenges, we're going to talk about workforce attitudes among public health and healthcare workers and perceptions as it relates to reporting to work and fulfilling role expectations in high dread events. So this is a very useful slide, I think. Excuse me. This comes from the formerly Institute of Medicine, now National Academies. And this is a depiction of what's in the US referred to as the Public Health Emergency Preparedness System. I have colleagues in Canada to whom I've presented this research, and their system is akin to the US, but again, different countries have different systems. So I don't mean to make this appear as monolithic, but I do think this is transferable to many different countries. So at the heart of this system, this is a hub and spokes diagram, as you can see. And at the hub of this system, we have the governmental public health infrastructure. That's a long way of saying health departments. And there's an old maxim that all disasters begin locally. So regardless of the magnitude of the event, the lead agency really is and should be the local public health agency, supplemented by state and federal and perhaps international assistance. Other actors within this interlacing system include Homeland Security and public safety, the private sector, so employers and businesses, the media, academia, so subject matter expertise, communities, and hospitals. So healthcare delivery systems refers to both hospitals and pre-hospital EMS systems. So all of these interlocking and integrated actors are critical when we think about the big picture of who executes public health emergency preparedness. So against that backdrop, there are a lot of ongoing challenges that frankly pre-existed COVID-19 in terms of preparedness in the US and have either been highlighted further by COVID-19 or exacerbated by COVID-19. And these include basically new expectations and ongoing expectations for public health workers and hospital workers in terms of responding to unanticipated kinds of threats, often high dread, often highly contagious. Look at Omicron, for example. Funding challenges, particularly in the public health sector. So public health agencies in the US have been underfunded for many years. That's not a novel statement. And so we have a very fragile hub of that hub and spokes diagram that I presented from a funding standpoint. Also, allocation of HD is health department personnel and resources. It's true also of hospitals. And diversity and preparedness levels, at least in the United States, for example, in terms of urban versus rural locales. On the right side, I want to highlight something called warning fatigue. And this is really a challenge when it comes to preparedness in general. And by that, I mean alarms about potential threats that don't materialize create sort of a crying wolf effect, fairly or unfairly. And so that can be a challenge for public health and healthcare workers. So if another potential threat is announced, theoretically in the next several weeks, there's that potential for warning fatigue. Well, will this really play out? A very important aspect, and this is appropriate for both hospital and health department employees, is a commonly asked question: where do I exactly fit in personally to the response? How do I fit in? And there's been a long-standing tacit assumption that if we train people to, in general, cover knowledge and skills that an agency or a hospital needs to address in response, that will translate into a sense of willingness to do so. So I can train someone how to look at anthrax under a microscope, but that doesn't mean that they'll be willing to come to work at anthrax under a microscope, nor does it mean that they know whether or not they fit into that activity of looking at anthrax under a microscope. So there's a multifaceted set of challenges there. We also need to think about mental health responses to public health emergencies and disasters. So one of the things, and I'm happy to, this is informal, so I'm happy to take questions along the way, is burnout. We have seen both anecdotally and sort of early stages of research with COVID-19 on considerations relating to burnout among healthcare workers. And all of that is germane to this focus of today's presentation, which is willingness to respond. And I just want to highlight that willingness to respond, as I'll present in the next few slides, is not the same as ability to respond, and it's not even the same as readiness to respond. And I'll clarify that in a bit. One thing that is a common sort of misnomer, and unfortunately it's been a long-standing one, is the word preparedness. It's almost used as a catch-all. So actually preparedness is one part of, and many, if not all of you may know this already, but out of due diligence I'm mentioning this, preparedness is just one part of what we call the disaster life cycle. And by the disaster life cycle, I'm highlighting that here. That includes prevention and mitigation. Ideally, we want to prevent public health emergency or disaster from occurring. Preparedness with a capital P is part of the disaster life cycle. And preparedness is its own pre-event continuous quality improvement cycle of planning, training, and drilling, and evaluating how we did on those drills, and then basically applying those insights toward enhanced response to future events. And that leads us to response. So I say half jokingly that when you see Anderson Cooper on TV in the wake of a disaster, you're looking at the response phase. And I say that only half jokingly because it is true that the media tends to focus most intensively on the acute response phase of an event in the minutes to hours to days to weeks. But what often gets neglected, including by the media, is the recovery phase. So there are parts of New Orleans, for example, that are still in the recovery phase following Hurricane Katrina, which is almost 17 years ago at the time of this recording. So we have to think of recovery as a long-term process that public health and healthcare workers play a frontline role in addressing. Recovery not only includes physical infrastructural recovery, but also, just as importantly, if not more so, psychosocial recovery. So how do we establish a new normal? That'll be a fascinating area to see how it plays out in an area of research, frankly, that I want to talk about in terms of examining recovery phase considerations post-COVID-19. So this is the disaster life cycle in a nutshell. And moving on, we're going to talk about a catch-all phrase that you've probably sure heard before. It's ready, willing, and able. And this actually, several years ago, colleagues and I published a concept paper where we took this common catchphrase, ready, willing, and able, and we sort of unpacked it and defined each of those terms in a specific way as they relate respectively to response and the quality of response to disaster. So let me just present them in a sort of an unorthodox order. I'm going to start with ready and then go to able and then go to willing. So readiness means, do you have plans in place for a public health emergency or disaster at your hospital or your health department? But not just do you have plans in place, do people know what those plans are? You can have the best written plans in the world, but if they're not clearly communicated or understood, I know this sounds obvious, but you'd be amazed at how often it's not applied in this way. You can have the best plans in the world, but if people don't understand what they are, how it applies to them, and how to execute them, it's like a tree falling in the forest. Readiness also at the household level means having a personal and family preparedness kit. And just parenthetically, rates of personal and family preparedness in the United States and elsewhere are abysmally low, and has historically through a variety of studies have been found that way. And at the jurisdictional level, what are your jurisdictional plans? What are your regional plans? What are international? So it's sort of concentric circles of readiness, but all of them refer to sort of plans in place and people's awareness of how those plans apply to them and how to execute them. Ability refers to what it sounds like, knowledge and skills. How do you use a two-way radio if you're responding to a public health emergency or disaster? What radio frequency should you use? Terms like interoperability are words that are commonly applied to this. So do you know how to clinically recognize the prodromal signs and symptoms of a given type of infectious disease outbreak? All of these are ability things and aspects. And historically, there's been frankly, a dangerous assumption that our research that I'll present has uncovered to be dangerous, because there's been an assumption for a long time in preparedness training that if you train someone how to look at anthrax under a microscope, for example, they'll be willing to come to work to look at anthrax under a microscope. And as I'll describe, that is a tacit assumption that unfortunately requires a paradigm shift to thinking not only training toward readiness and ability, but also to willingness. And that's what I'm going to focus on for the rest of the presentation today, and how willingness is so relevant, why it's relevant, and what are its constituent drivers. When we think about willingness, it's important to go back a little bit, actually almost 3.5 decades now, to really seminal work by a researcher named Paul Slovic from University of Oregon, now with Decision Research in Eugene, Oregon, who in 1987 published a very important paper, I think, in Science, where he described what are called axes of risk perception. And the idea here is that and the reason I mention this is that public health and healthcare workers are as prone to fear as anyone else. Just because they signed up for a job, or maybe they didn't sign up for what they're dealing with now, they still have the same human fears that everyone else does. And so that's another sort of tacit important underpinning of this presentation. In any event, Paul Slovic identified 2 axes of risk perception called threat and observability. In other words, according to the way he postulated it, the higher the perceived threat, the higher the perceived risk. And paradoxically, the less observable the threat is. So for example, radiation, ionizing radiation can't be seen, smelled, tasted, or touched. It's intangible. So the less observable it is, the more frightening it is. Guess what is also not physically observable? A virus. We can see the effects of the virus, but we can't see the virus itself unless you're looking under an electron microscope. So this is how Paul Slovic in this 1987 very important paper presented these various factors, excuse me, that relate respectively to threat and observability. And anything in the northeast quadrant, if you will, of this biaxial diagram is something that would be considered high risk perception, because if it's not observable, unknown to those exposed, effects delayed, new risks unknown to science, boy, that sounds a lot like COVID-19 with all the new variants that have emerged, for example. It also is true of other kinds of threats that we may not yet know are in the offing. Also, perceptions about uncontrollability, dread, globally catastrophic, not equitable, high risk to future generations, and other aspects of involuntariness, all of those increase the threat. So anything in this northeastern quadrant, if you will, of this diagram fits under the high risk perception category. Now, I just want to highlight that willingness to respond is not just some academic thought exercise. It has real world implications and real world examples, unfortunately. So this is a report from NPR from early in the pandemic, March 24th, 2020. You'll recall it was declared by WHO on March 11th of 2020, COVID-19 was. And this is a report about Spanish military finds dead bodies and seniors completely abandoned in care homes. And by the way, I want to highlight, I'm in this work, I'm not in any way diminishing the heroic work done by so many in healthcare, but it is absolutely critical to understand gaps in willingness too, because this is an all hands on deck kind of events, and so will future emergencies, public health emergencies and disasters. Many of you may know my colleague, Dr. Tom Kirsch, an emergency physician formerly at Hopkins. I think he's still affiliated with Hopkins, and now he's at Informed Services University. I really highly recommend this article. He wrote it on March 24th, 2020. If you read it now, it's almost like he was a fortune teller. He talked about the grinding down of the healthcare infrastructure, the fatigue, things like burnout, the kinds of things that we have seen, and he he connected it to concerns about what if healthcare workers stop showing up. And as you may have seen, it's been very difficult, for example, to hire nurses in many cases. There have been a lot of people who have retired early from health work in the United States during COVID-19, just from sheer fatigue. And this is not an ad hominem critique. These are understandable considerations, but this I highly recommend. It's still available. If you Google Atlantic Tom Kirsch or Thomas Kirsch, you'll see this really excellent piece that he wrote. By the way, these considerations are not just germane to COVID-19. They're also highly relevant to other kinds of events that we've experienced, and these are actual headlines. These are not peer-reviewed journals, but these are important just the same. So this is a news report. You'll recall the 2014 West Africa Ebola outbreak, and the gentleman who flew from Liberia to Dallas was the first case in the United States of Ebola. He tragically died from it. And this is a news report from the New York Times. This is someone obviously in a hazmat suit. I doubt this is that person's first rodeo in a hazmat suit, but you'll see the headline is "Delay in Dallas Ebola Cleanup as Workers Balk at Tasks." So even hardcore, quote unquote, individuals who do this for a living have fears, anxieties, and things that can make them more reticent to come to work. Here is an article that describes how there was a nurse from a hospital in Madrid who took care of a physician who was working with MSF, the nurse became ill with Ebola, and there was widespread quitting among hospital staff following her becoming ill. Here is, some of you may have worked in Liberia during this outbreak. If you did, excuse me, you may recall that there was an 11th hour strike among health workers in Liberia, narrowly averted because of concerns about insufficient hazard pay. And frankly, that's not a critique. It's understandable, these kinds of concerns. In Bellevue, at Bellevue Hospital, which is one of the designated treatment hospitals for Ebola in 2014, there was a different physician with MSF who came to Bellevue Hospital, and then, as was reported in the news subsequently, there was widespread calling in sick at that hospital. And I don't think that is true and unrelated. So from a more rigorous sort of research design standpoint, my colleagues and I have been looking at this question of willingness to respond for many years now. And one of the survey instruments that we've developed to examine willingness to respond among public health workers, for example, is called the Public Health Infrastructure Response Survey Tool. And it uses a behavioral model that, that underpins it, that I'll present in a second, and it's a threat and efficacy behavioral model. It's called the extended parallel process model, and it's actually quite intuitive, but it's important that to just quickly review, which I'll do in a moment. In this survey, we examined willingness to respond for various types of threat scenarios. So weather-related disaster, pandemic flu, so these are naturally occurring. Dirty bomb, which is ionizing radiation mixed with TNT. The amount of radiation is relatively small. The amount of fear is enormous because radiation is, as Paul Slovic identified, is a very high risk perception threat based on those axes that I presented from his work. And inhalational anthrax. You may recall the anthrax mailings in the United States that immediately followed or soon after followed the September 11, 2001 terror attacks. So let me walk through this example. And let's say we were I was trying to get someone to make a preparedness kit. So this is the extended parallel process model, and I'll use my cursor to illustrate. The model says I need to do two things. Let's say I'm talking to someone in Florida and I'm saying, you need to get a preparedness kit for a snowstorm. Well, that according to this model is a non-starter, because if they don't perceive the threat as high or relative or relevant to them, they will not be likely to endorse the message, and they will disregard it and reject it. However, if someone's in Buffalo, New York, and I say, which is obviously high area of snowfall, or area of high snowfall, and I say, yes, you should make a preparedness kit for snowstorms. Well, okay, people can endorse that idea because they've experienced it. And in that case, if the answer is yes, my job is not done. I also have to convince them of something called efficacy. And there are two types of efficacy that are relevant to this model. One, which we've found to be the most, this is one of the take-homes for today, the most influential driver of willingness to respond is something called self-efficacy. It's a concept pioneered by Albert Bandura from Stanford. And self-efficacy can loosely be translated as confidence to deal with situational uncertainty, but having a sense of underlying confidence that one can perform effectively nonetheless. The other type of efficacy, unfortunately, has nothing to do with the disaster life cycle. It's called response efficacy. It's a communication term. It means, do I perceive that I matter? So these are two types of efficacy, but they're both part of this model. So let's say that I've convinced someone of the legitimacy of the threat, but I fail to convince them of the efficacy. According to the model, they will be frightened and not having a sense of efficacy, and they will engage in denial or avoidance reactions to not deal with what I'm encouraging them to do, make a kit, but rather they'll do sort of magical thinking, fear, which is called fear control. It's a maladaptive response. You can see that right. Oops, sorry. Go back a slide. You can see that right here, and that will lead to message rejection. However, if I can convince the individual of both the legitimacy of the threat and the efficacy of the intervention, in this case, making a kit, that person, according to this model, will engage in a positively adaptive response called danger control, in which they will actually be more apt to adhere to the message and accept it and make a kit. Now, there's a great expression. I wish I could say that I coined it. I did not. It was developed by biostatistician George E.P. Box, who said that all models are wrong and some are useful. And that is very true of this too. So it turns out, one of the take-homes from today's presentation is that when it comes to training curricula designed to boost efficacy, and we've done randomized controlled trials to show this, it turns out that efficacy, to boost willingness to respond, it turns out that efficacy weighs more than threat as a modifier of willingness to respond. So that means if we're going to redesign preparedness trainings and curricula to enhance willingness to respond, we need to focus not just on knowledge and skills, but on the efficacy piece, giving people a sense of confidence that they know how they would perform, what their jobs would be, and they have a sense of confidence that they can do it effectively and that they matter in doing so. So that's where the efficacy outweighing the threat comes in. So that means that we need to think about focusing on efficacy-oriented training to boost willingness to respond. And that's a radical paradigm shift, frankly, from how preparedness trainings have been done forever, which is, well, we just teach people what, the clinical signs and symptoms of X, Y, or Z are, and just assume that people will show up to work to respond to it. If you had to pick, now one thing I want to also highlight as a take-home message is that willingness to respond is scenario specific, even within an individual. In other words, based on our research, my willingness to come to work in a pandemic flu event may be lower than my own respective willingness to come to work in a radiological dirty bomb event. And as it turns out, going back to Paul Slovic, who found that radiation has the highest fear of all environmental hazards that he looked at. Turns out that the scenario that we've studied that has the lowest rates of willingness to respond across all occupational sectors is the dirty bomb, the radiological terrorism event. But having said that, if we had to sort of synthesize and try to pick one profile that's more of a worker who's in public health or hospitals, who's more apt to be willing to respond across all hazards, it's what we call the concerned and confident worker. Concern means high perceived threat that motivates that worker to respond to it because it's grabbed their attention, it's motivated them, and confidence, which is the same as efficacy. I'm just using it as a synonym here. So the concerned and confident worker is the most apt to be willing to respond. So in this case, concern is actually a good thing. Concern can be motivational. Now, we don't mean concern out of proportion to the threat or less than the threat, but proportionate to the threat coupled with that high sense of confidence. And we can build confidence, as I'll show you through some randomized controlled trial studies that we've done, through efficacy-focused training, as I mentioned. We've looked at a variety of cohorts to examine willingness to respond to date, including hospital workers. We did a study of workers at Johns Hopkins Hospital, and these are in the references section. I'm also happy to further describe if you have follow-on questions at any time, or even during today, obviously. We looked at willingness to respond among hospital workers. We've looked at willingness to respond among local health department workers in the United States, EMS workers in the US, and Medical Reserve Corps volunteers. You would think intuitively, perhaps, that someone who's a volunteer would be willing to sign up for anything. What we have found is that willingness to respond among volunteers is also scenario specific. So just because someone's a Medical Reserve Corps volunteer, their willingness to come to work in a radiological event was much lower than their willingness to come to work in other kinds of events. So I mentioned this earlier, just to reiterate, efficacy outweighs perceived threat as a modifier of willingness to respond. And the single biggest modifier of willingness to respond per our research is self-efficacy. And the great thing about Bandura's finding is he found that what one says about one's own self-efficacy is predictive of one's actual real-world behavior. So we're actually able to build and extend upon the seminal work that Bandura has done to really apply it to these contexts. And as I mentioned earlier, and consistent with Paul Slovic's findings, with radiation, the dirty bomb scenario has consistently lower rates of agreement for willingness to respond to related constructs than the other scenarios that I mentioned. Now, this is a slide. I could have picked hundreds of slides, but this is one department at a hospital that you probably know quite well. And in fact, this is from the study I mentioned earlier. And this is willingness to respond in different contexts for physicians versus nurses for pandemic flu versus dirty bomb. So take home message from this slide. Willingness to respond is very much related to organizational expectations. If the organization, or the hospital in this case, requires employees to come to work, they are more apt, whether physicians or nurses, to be willing to respond regardless of the scenario. Now, I should mention that you may say, oh, 78%, that's not so bad. Well, as you're well aware, nurses are by far the largest contingent of healthcare workers in the US and internationally. So basically almost a 22% deficit in willingness to respond, even for a pandemic, is a huge surge capacity threat for hospital systems. And look, it's even almost 30% for nurses there. It's also 15% for physicians here. So, but if one were to think about this from an organizational or programmatic or hiring or contractual standpoint, requiring someone to come to work, even though one cannot drag someone to work, one can, as a colleague of mine once said, I can't make my employees come to work, but I can revisit their employment status afterwards if they don't. So the stick approach seems to matter. If asked but not required, the rates respectively for these scenarios and job cohorts are lower than if required. And then when you ask the same question, would you be willing to come to work in a pandemic influenza event? And this is pre-COVID-19 surveys, I should mention. Regardless of severity, look at the rates for nurses, 50%. So can you imagine if half of the nursing workforce, or even, let's say that we're being let's be more conservative than that. Let's just say some people who answer a certain way actually do show up. That's still a huge deficit for surge capacity, and 17% of physicians for that. And when you look at the radiological dirty bomb scenario, it's even more profound in terms of these deficits. So we really need to address the elephant in the room of willingness to respond. That's what these data point to. And we'll talk about some, as I mentioned, some randomized controlled trial related curricular intervention research that is intended to address this. One of the things we found in our Hopkins Hospital study is that nurses in this survey were less likely to be willing to respond than physicians. You can see the odds ratios here. So 0.6 in a pandemic emergency, and that perceived pandemic flu emergency, excuse me, and perceived threat had little impact on willingness to respond in the dirty bomb scenario. That speaks to our earlier point that efficacy weighs more than threat as a modifier of willingness to respond. Let's talk now about health department workers. So I was leading a study. This is a study that was conducted from 2008 to 2013 approximately across 71 health departments in 9 states. The largest survey that I'm aware of that has been done to date in the US or elsewhere of willingness to respond among public health agencies. And you can see that half of the we call them clusters. So these would like be, a cluster would be like 3 adjacent counties in Idaho that are exposed to similar hazard vulnerabilities and so on. So we had 4 rural clusters and 4 urban clusters, almost 3,000 enrollees in this study. Again, you'll see some similar findings to the table I showed earlier from the earlier slide about anesthesiology and critical care at a tertiary quaternary hospital. Similar patterns here. Lowest rates of willingness to respond are for the dirty bomb, whether required, asked but not required, regardless of severity. And for each respective scenario, you see that it matters in terms of organizational expectations. Highest rates respectively is if required, next highest is if asked but not required, and lowest if we ask regardless of severity. So in order to examine this, we didn't want to just diagnose this as a problem. We wanted to see if there are curricular interventions based on this extended parallel process model that I shared earlier that we can apply toward boosting willingness to respond by efficacy-oriented, efficacy-focused training. And so we developed an experimental curriculum based on this efficacy-oriented aspects of response called the public health infrastructure training here. Basically this was a train the trainer curriculum. So I went out to these various states and jurisdictions and conducted trainings for public health workers who would then train their colleagues in this. One of the things we found is, not to use too much of a clinical analogy, but this is better as this kind of training to change attitudes is better as a slow IV infusion than a bolus kind of training, because if you do a sort of a crash course, a one-day training, you may have a halo effect of increased attitudes, but it dissipates. So we wanted to infuse this slowly over a 6-month period intentionally, and most health departments were actually appreciative of that because that was more consistent with their workflow. We had a variety of multimodal training approaches, face-to-face lecture and discussion, online learning, and you can see the rest here. We did tabletop exercises for this study, which was a CDC-funded study. We focus on the scenario that had the lowest baseline rate of willingness to respond, which, not surprisingly, based on what I presented earlier with respect to Paul Slovich's finding, was the radiological dirty bomb scenario. So this is just sort of a table of contents describing what we had, the various activities we had people conduct. One of the things that we did is we asked people to describe events that have happened in their jurisdiction. That is part of the perceived threat, even though efficacy weighs more than threat. By having people describe disasters that have occurred in their jurisdiction, it makes it more real to them. So it's not just some sort of abstract training. We also did what's called an emergency scenario contingency planning exercise, where we asked people what would be the impact positively on yourself, your family, your agency, and your community concentrically, respectively, if you come to work. And for example, so this was a discussion exercise, and people would say, well, for benefits to self, I'm proud of myself for participating in response? What's the benefit of my community? And people came up with wonderful, like rich answers here. What's the benefit to my family? Well, I'm doing my job, which in turn keeps my family safer, because who else is going to do it if if I'm working for the health department? By staying at home, I'm not really helping my family. I'm helping my family by doing my job as a public health leader. Agency, improved agency morale, helping one another out. A well-functioning agency. And then the last of the concentric circles is community. So the idea is, what are the benefits to my community? Is, well, I'm helping my community stay optimally safe, continue to function well, and so on. We did independent learning activities in conjunction with this training. Even something that may seem very simple, but was quite interesting. We had people print out their local maps for their communities and draw out multiple routes to work. Now you may say, oh, that's ridiculous. Well, we all have certain ways that we get to work, and certainly in the pre-COVID times, that was probably more germane than the telework age, but certainly in clinical work, we still have to drive to work. And what if I-83 in Baltimore were blocked? What alternative routes? And it was amazing. We did mixed methods research, and we found from focus groups that people often just sort of assume there was one way that they would always go to work. And so getting them to think outside the box in that regard was very critical. Last but not least, we did tabletop exercises, discussion-based exercises, which was allowed all participants. And by the way, we had people intentionally in the room ranging from senior most administrative officials to clerical and support staff, which was very important because in a no consequence or no fault environment, to have everybody's perspectives represented in this tabletop exercise. So we did basically, we focused on the dirty bomb scenario, and we did role playing for risk communication and a debriefing, like a hot wash. So I'm just going to present to you a few key tables from this work with health departments. What you see here is the way to view this is willingness to respond regardless of severity. And we did 3 surveys. We had a control arm and an intervention arm with synced surveys at baseline before the curriculum. That's the farthest left number. Then we had a survey administered at 1 month post-curriculum, synced up here, and then a survey at 6 months post-curriculum. So one of the things we found, it's always good when the control doesn't show any pattern at all, which it did not. It did seem to have more of an impact, this curriculum seemed to have more of an impact on high dread events per Slovich's model. For example, the radiological dirty bomb event. So at baseline, 57%, per my cursor here, of the intervention arm were willing to respond to a dirty bomb regardless of severity. That went up after the training upon 1 month resurvey to 73% and only dropped 2% from there at 6 months. So a net 14% increase. You may say, well, that's not that much. That's actually a big amount because these are all hands on deck events. If you're at Baltimore City Health Department, for example, there are 1,300 employees. 14% of 1,300 is a large number. And so these are the kinds of insights that we glean from this analysis. Self-efficacy, I mentioned, we found from our research, is the most influential driver of willingness to respond. And excuse the background with the ambulances. When we looked at, again, the various scenarios, we found the control arm not showing any pattern at all. And really the impact, and again, we focus on the scenario with the lowest baseline rate, which was the radiological dirty bomb. At baseline, 50% in the intervention arm were willing to come to work, or excuse me, had self-efficacy, high self-efficacy. It went up to 79% at 1 month and dropped 4% from there. So a net increase of 25% in self-efficacy at 6 months, which again is important finding because, as I mentioned, self-efficacy is the leading predictor of willingness to respond. Also, as it turns out, very fortunately, what Albert Bandura, who pioneered self-efficacy, found is that what people say about their own self-efficacy is actually predictive of real-world behavior. So we got a little lucky there based on the very seminal foundational work of Bandura. So I want to conclude with some current research and next steps, and some of these involve people you know. So I'm currently working on a Fogarty NIH grant. I'm a co-PI with Dr. Junaid Razak and Dr. Nargis Assad from Dr. Razak, as you know, is now at Cornell, and Dr. Assad is at Aga Khan University in Karachi, Pakistan. And so we are working on this study using mixed methods research to assess gaps in disaster response willingness among emergency department clinical-based personnel in Pakistan. And what really is exciting, in addition to understanding this question from an LMIC context, is we're going to use these findings through this study. This is an R21, R33, to develop, pilot, and assess the effectiveness of a novel mHealth app for enhancing response willingness. And to our knowledge, this has never been done to date. So this is very exciting in terms of next steps avenues for our research. Another area that, as I mentioned earlier, I think is ripe for additional research, especially in the aftermath of COVID-19, is going to be public health and healthcare workforce attitudes in disaster recovery and how that intersects with burnout and those kinds of considerations. So these are all very timely topics for current and future analysis. So here are some references, selected references. I'm happy to furnish additional ones to anyone who would like, and these are all available through Welch Web. And thank you so much, and happy to answer any questions.
Thank you, Dan. That was really excellent presentation. I think you can leave your contact information up there for a bit, and then we can probably go back to just a view where we can see each other.
Sure.
It was a lot to take away, even going back to some foundational frameworks in disaster science. I learned a lot personally. So let's open up the floor. Any reactions, thoughts, questions?
Hi, thank you, Dan, for that presentation. I do a lot of work in disaster preparedness and planning and management in pediatrics. And actually, I might invite you to speak if you're okay with it. I do a 2-week disaster elective for my residents. And I do a willingness talk. This definitely incorporates a lot of what I talk about, but a couple other items, and I like how you presented it. I wanted to also bring up that there's some studies in out of Saudi Arabia that talk about willingness to respond that really give really good context. So not sure if I would include that in the low income countries, but it definitely gives another context outside of the US.
Absolutely.
That speaks exactly to what you've been talking about too.
Thank you for those comments. Another recent research venue has been Yemen. And
Yes.
There's been some initial research out of Yemen regarding COVID-19 and willingness. So this is a really timely topic and sort of LMIC context to be studying in general, whether it's LMIC or not internationally. Exactly right. Thank you.
Yeah, and I will definitely be emailing you in the near future.
Oh, my pleasure. Thank you. Okay, I see some chat questions.
More observing Milton.
Some comments about
I'm not desperate to hit the red button.
Dan, I was wondering if you could maybe off the top of your head, just if you could summarize some of what you think are some of the most efficacious, positive, not punitive interventions to increase willingness to respond. That if you were running a health program or somebody asked you to come as a consultant to work on this problem, what are some of the approaches that you've seen in your research that demonstrate real value?
Sure, it's a great question. One is there's a study out of Columbia that was quite well done that looked at incentive. This was pre-COVID-19, that looked at incentives for enhancing willingness to respond among hospital personnel at Columbia Medical Center. And they found that if staff were given priority access and their families were given priority access to vaccines and antivirals, that was a programmatically very influential boost for willingness to respond. One of the things we've also found, interestingly enough, is perception of social norms from our study at Hopkins Hospital back in 2010, which happened to paradoxically coincide with 2009 H1N1. Individuals who perceived that their coworkers would come to work were almost 17 times more likely themselves to indicate they'd be willing to come to work. So creating an organizational culture of willingness, if that makes sense, has a sort of a positive feedback loop effect we've found. And the other part, I would say, Nico, is really revisiting the paradigm of training, not just indicating what the signs and symptoms of X, Y, and Z are, but how and why that particular employee matters in the context of the overall response. So one of the activities we've done that we found, at least in health department, can be a boost, is having people with their job action sheets that people have that describe their day-to-day roles, and then crosswalking those day-to-day job action sheets for blue sky days, as they call it, to what their respective roles would be in a disaster. And we found that had dual benefit, because on the one hand, people basically said, oh, I actually have a role to play in this all hands on deck context. And also people were reassured that if their job is in fiscal, they're not going to be asked to vaccinate people, which I know sounds ridiculous, but when people, I'm sure you've probably heard that, for example, at USC, this is really impressive, I think, what they did at USC Keck Medical Center, surgical residents got trained in nursing to respond to COVID-19. I love that, okay, because that shows institutional agility. But the idea here is being able to crosswalk or even learn either just in time or other kinds of skills that are not totally off the charts from what you do on a daily basis, but are relevant to it and can be brought to bear to enhance overall institutional response. Does that make sense in terms of those aspects? So those are my based on at least the literature such as it is right now.
And that's super helpful. A number of us are working for like this JPIGO project, which is supporting emergency response for COVID-19. And so like, this is like probably like the next thing we need to think about, right? Which is maintaining your skilled healthcare workforce, not just training your healthcare workforce. Another study that a couple of us have been working on is some CDC work looking at regional capacity for public health response. And, as you know, there's a lot of training available in terms of rapid response teams training with WHO and then FETP and then TEFINET. And so I've been on like at least 7 Ministry of Health level conversations where we've talked about like, what are the needs for public health response? And they're like, well, it's fine that CDC and WHO has all these trainings, but then these people learn and then disappear. And so I don't know, I haven't wrapped my head around like what the proposed solutions here should be, and I would love your insights, but how do we ensure that the training is for the right individuals? And then how do we maintain that skilled workforce and their willingness to continue to participate after they've been in training? Because I do feel like there's a mismatch, especially when we are PEPFARizing all of our indicators and saying number of people trained, but then those people aren't the ones that are actually doing the response.
It's a wonderful question, Bhakti. I think a few things about that. One is that goes back to the crosswalk activity. So let's say someone is a clerical and support staff. In our pilot study, I did mention this, but we did a pilot study in Maryland looking at 3 health departments. This is way back in 2005. And we found that clerical and support staff were 2.5 times less likely to be willing to respond than non-clerical and support staff. And one may say, well, gosh, they're just clerical and support staff. Well, no, they're actually on the front lines of crisis risk communication. If you put a fact sheet in front of such an individual who's skilled at talking to the public in general, they can augment your risk communication surge capacity. And if there are more complex questions, they can refer those questions to, if there is a hotline or other kind of a mechanism, to someone who is more scientifically trained. So I think to your point, I think it's about training. It's all hands on deck is the first take home. Everybody matters and everybody has a role to play, but explaining specifically how one's day-to-day job action sheet, if you were to have like left side of a table, imagine day-to-day job roles and skill sets, right side of the table respectively, how those skill sets apply to COVID-19 response. And you were to fill in that table for people, we found that that creates like an aha moment where people say, okay, I see. You're not asking me to, I'm in fiscal, you're not asking me to vaccinate anybody. Oh, but you are asking me to manage inventory and do backfill and those kinds of things that I, pretending I'm the fiscal person, am quite good at. But now I understand how it fits into the current response. So some of it is a bit just-in-time training, admittedly, but a lot of it can be done pre-event, pre the next pandemic. And I know I'm talking to the choir. I highly doubt this is the last pandemic we're going to see in our lifetimes. And so, frankly, I know it seems like a fatiguing moment to think about, oh my gosh, future pandemic training, but there can be sort of a, I hate to use the phrase win-win, but by doing these kinds of, even during intra-event trainings, or just even guidances, they don't have to be trainings. People are too tired to do trainings right now. They're living training right now. But the idea is that if these concepts can be interwoven into current activities, it becomes sort of a learning by doing, which can then ostensibly, hopefully, I think more research needs to assess this, enhance future responses because it becomes real to people. That was a long answer to a short question, Bhakti, but I hope that was helpful.
No, I actually think like one of the big problems is like all of these trainings, right? So the RRT is 5 days, and the people who can take 5 days off to sit in a room and listen to a lecture about hand washing are not the ones that are going to be responding.
Nope.
So I think this idea of integrating or interweaving, which I think is a good terminology, disaster preparedness as part of like annual skill refreshers, right? For example, would make a lot of sense. And then I think the other thing that you spoke to me was about RACI, right? Like maybe it's really about doing a RACI or a responsibilities accountability matrix currently, and then in a state of emergency.
That's right, and exactly. And I also think it's important for onboarding new employees who, have to get acculturated to the new normal of what hospital work is in a COVID world, even a post-COVID world. I think one of the areas that I didn't talk about, or I mentioned briefly, is studying willingness to participate in disaster recovery, which sounds counterintuitive. Well, of course, they're going to be around because they're still around and recovery is going to happen. So by definition, they'll participate. But we found through a study of health departments in Maryland and New Jersey that about 20% said, this is after Hurricane Sandy, said, I don't think I'm willing to participate in future disaster recovery efforts. So these are things that can't necessarily be assumed, but are, I think, relevant to all phases of the disaster life cycle, particularly response and recovery. Great question.
Well, great presentation. This is super exciting. And then I think there's like another group of us that's not on this call that is more disaster focused. So if you don't mind, we'll share a recording with our colleagues who are more disaster focused within the department as well.
My pleasure, absolutely.
Yeah, we just have 1 or 2 minutes left if anyone else has any questions. I have one last burning question, Dan. It may be a can of worms because it's more of a musing than a question, but I'm wondering, since you spent a lot of time thinking about this, what do you think of the hero paradigm? I know, in this pandemic, healthcare workers became heroes, and maybe stereotypically soldiers kind of embraced that, but I know many of us were uneasy with it because once a group or a person is a hero, right, all of a sudden they're expected to sacrifice, and it's sort of taken for granted, right? And there's something more than that to it, that if they choose not to sacrifice, if the willingness isn't there after you've called them a hero, it's more of a betrayal than a normal person doing that, right? It's traitorous. And so I know many healthcare workers that have felt that it's a problematic title. it creates problems when they demand a better PPE or hazard pay or anything like that, because the hero title almost works against them. I noticed in your list of interventions that you would recommend for improving willingness, you didn't list calling people heroes.
That was intentional.
Yeah, and I don't think it's not like an organized response, but it's almost like a societal subconscious thing to do. Like society, when you want to pressure a group of people to do something, one of the things you could do, I guess, is call them heroes. I don't know. Do you have any thoughts on that?
It's a great question. So I think the heroes is a very fraught term, because in it, like you said, Nico, it actually puts more pressure on people to stay heroes, and doesn't acknowledge the human frailties that we all have. Also, there's a concept that's very relevant called compassion fatigue. And the idea that, you all have lived this, anyone who's been responding to COVID-19, it is exhausting, emotionally exhausting. And so to sort of put someone at a pedestal level where there's nowhere to go but down in terms of the reality that they're experiencing versus where they're being elevated to in terms of sociocultural perception, is just, it's kind of a setup for a fall. And so I think one of the things we've found, though, is thank yous and appreciation. This may sound very trite, but it actually works. From our others, we found this through our research, that thank yous and appreciations from senior administrative officials go an amazingly long way. Not even pay raises. I'm not talking about, I'm just talking about a thank you or some sort of an appreciation and a sort of a formal acknowledgement can go a long way toward boosting morale, and by extension, enhancing willingness to respond. So it's amazing how simple things like that, from the CEO of a hospital or the head of a department or someone in a position of seniority, can really be that shot in the arm. No pun intended, by the way. I don't know why. But yes, you see what I'm saying. Does that make sense, though, in terms of?
Yeah. Yeah. Thank you. It's been a true pleasure. I think there's a lot to take home, and for the folks who aren't here, I think they're in for a treat when they see the recording. So we hope to see more of you, Dan, and thanks for speaking with us today.
Thank you for having me.
Thanks everybody else for attending.
Thanks, everyone.